So chapter 3, medical, legal, and ethical issues. One of the first things we're going to talk about here is your scope of practice. Somebody out there tell me, what do you think your scope of practice is? All right, this is where we come to our first learning objective. I'll wait. What do you think your scope of practice is?
Like what you're allowed to do to people for like care and whatnot, and like what
Yeah,
you're not allowed to do.
it's your scope of practice, really simply put, is just that. It is what you're allowed to do. The things that are inside that textbook are going to be your scope of practice as far as the National Registry is concerned. That doesn't mean that there isn't going to be additional things that you can do here in the state of Massachusetts, or maybe some other things that you can't do in the state of Massachusetts. But your scope of practice is just that. It is what you are actually physically trained to do. It is all the things encompassed in that textbook, and it is all of the things that we're going to talk about. So you'll come to terms with the fact that there is going to be certain things that are just outside of your scope of practice. If you look through that textbook page by page, there are things that you will not find in there that maybe down the road, as you become a more seasoned like veteran EMT and have a little bit more experience under your belt, you may know, hey, my patient needs this, but you are not able to accomplish that as a skill because it is outside of your scope of practice. Some of the more invasive, bigger ticket items like intubation and IVs and cardiac monitoring require training that is 10 to 15 times longer than this class all by itself. And they're things that we just don't do at the basic life support level. So when we know something is not a procedure or skill that we've been trained to do, we know that legally it is outside of our scope of practice and it is not something that we should be doing. You'll see as we get a little bit later on in the program when we get to, let's see, it's chapter 41 in the 11th edition. I believe it's listed as chapter 9 in your textbook, the healthcare as a team. You're going to work hand in hand with paramedics who are legally bound to perform some of these more invasive, more high-level things, but everybody has to stay in their lane. Yes, you can assist with those things, but in no way, shape, or form is it within your scope of practice to actually be passing an endotracheal tube through somebody's vocal cords and inserting an advanced airway. When we get into all of that stuff, you will have pretty cut and dry ideas of, yes, I can do this, no, I cannot do that. And realistically, knowing what you're allowed to do and what you're not allowed to do is way more important than knowing how to do it. There's lots of stuff I've learned in 20 years. I'm allowed to do the BLS level procedures, the BLS level skills, and that's a wrap. Just because I know a lot of stuff because I'm a student of the game doesn't mean I should be out there running the streets doing whatever I want. So we've hit scope of practice. You guys nailed that down pretty good. Now, tell me what you think the standard of care is.
Is it like the amount of care you give?
So, yeah, pretty much. Standard of care is what someone with similar training and similar experience would be expected to provide to a patient in a similar situation. So it's sort of like measured against reasonable standard. You know, if you show up to a call and you do everything that you can under your scope of practice to a reasonable level, you have met the standard of care for that patient. Now, when we talk in a few minutes about things like negligence and misfeasance and malfeasance and all these big fancy legal terms, we're measured against that standard of care. Would somebody else who has the same level of training and the same amount of experience as you have done the same thing? It really is just that. Is what you did reasonable? And does it follow along with your scope of practice and your BLS treatment protocols? The state of Massachusetts has BLS protocols for just about everything under the sun. And there are things that our performance in the field are actually measured against. Did we do right or did we not do right? Now, what do you think happens when somebody makes a mistake?
They pay for it?
Sort of, but they don't pay for it nearly as much as I think everybody thinks that they do. The big thing that we'll talk about here is, Elon Musk is never going to invent something that is going to be out performing the duties of an EMT. This much I can assure you. So we are human, and to err is human. The things happen, mistakes get made, people forget things or think they did something that they didn't, especially in such a rapidly changing fluid environment. The big thing with making a mistake in the field of emergency medicine is, number one, owning it, and number two, shooting straight about it. So yes, just admit that you made a mistake and learn from it. And nobody is standing there waiting to tear up your EMT certification most of the time. You may need some remedial training with somebody like me in a classroom down the road. The state may ask you to complete a project to show that you've learned your lesson and you wouldn't make the same mistake. But they're not just out there hopping mad waiting to steal people's livelihoods from them, because they understand that in these types of chaotic environments, I mean, look at the picture on your screen. That's Route 9 in Newton, and there's probably traffic going by on the other side at around 50 miles an hour. There's people all over the place. There's apparatus everywhere. There's state troopers. There's a Cataldo ambulance. Does that not seem like, the epitome of controlled chaos as we look at it? In those situations, I'm going to tell you that it is easy to make a mistake or miss something, or, there's so many people involved in the care of these patients that I thought they did it, they thought I did it, nobody actually did it. So as long as you are constantly evolving and constantly learning and constantly striving to meet that standard of care, things generally work out well for you. When people get in a pinch, it's because they didn't meet the standard of care. They try to cover it up. They don't learn anything from it. And then a week later, they make the same mistake. Mistakes are just going to happen. So moving on through into our legal duties, what is your duty to act?
When something is going wrong, it's like your legal duty to help type stuff.
Absolutely. It talks about your legal obligation to provide care. So your duty to act in the state of Massachusetts begins and ends when you punch in and when you punch out. If you are minding your own business, wandering through aisle 2 of the market basket, and somebody goes into cardiac arrest, and you don't feel like touching a dead person on your time off, that's up to you. If you're on the clock picking up lunch, guess what? You own that dead person in aisle 2 of the market basket.
On this section, I had I did one attempt at the quiz. So I got this question wrong because I think I said something along the lines, you don't need to help, but it's not your obligation to help. But when I think I clicked the wrong one, but I had a hard time understanding what it meant, even in the textbook, when I had read it again.
So would duty to add just the straight definition of your duty to act?
No, so when I answered the question, I thought that your duty, when I answered it almost like your duty to act is mainly just when you're working. I thought of your duty to act was more of just when you're on the clock. It's not you can act if you want to outside of work, but you don't need to. So I answered it as if you only have to do it if you are on the clock.
And truth be told, that is the way it actually works here in Mass.
Okay.
I'll look up in the book and see if I can get you a page reference for that question.
Okay, thank you.
Sure. So We have a couple of other duties here. It's not just duty to provide service and to provide care and transport for somebody, whether we think they needed an ambulance or not. We have some other duties, and they don't exactly fall in the list of order that they have them up here on this screen. Now, the duty to the patient, sure, that involves respecting their rights, being an advocate for them, protecting and honoring their wishes, absolutely. But guess which one comes first?
Duty to act.
Duty to self,
Duty to self. How come?
Duty to patient.
because you can't help anyone if you can't help yourself.
Right. If you turn yourself into another patient because of maybe some unsafe scene or, how about exposure to a hazardous material? We have a patient down and we just go rushing into somewhere we have no business being. You actually make yourself another patient. And by making yourself another patient, you turn into a negative on this whole situation. One of the things that you will hear me say over and over and over and over and over again, and these are words that you should learn moving forward, are scene safety and either body substance isolation or PPE, personal protective equipment. Because the first words out of your mouths at every single station at your practical exam, when we get there in a month, are going to be scene safety BSI or scene safety PPE. Because the first duty you have is to protect you and to protect your partner. So if the scene is unsafe or you don't have safe access to a patient, your duty to act is null and void. Until your safety and your partner's safety can actually be verified and be accounted for, you don't have any duty to act. You don't have any duty to a patient. We don't just go running into burning buildings because we think somebody might need some treatment. Sure, will we go in once the fire is contained and put out, or will we wait for the fire department to bring people out to us? Absolutely. But what I'll tell you is your Cataldo uniform is not flame retardant. It is also not bulletproof. So duty to self and duty to your partner are first and foremost. After that, we get into duty to the patient and duty for our equipment. What do you think that means?
Well, duty to patient should probably be just the respect that you have for them, or the actual commitment that you're looking to do the best that you can. And then I would say duty to your equipment would be to properly take care of it or maintain it so that when you need the proper equipment, it works for you.
Spot on. Take care of your stuff so that someday your stuff will take care of you. You're absolutely correct. I think that's something that's a lot of times overlooked in the field. We get so focused on taking care of the patient and doing things as best we can and doing things, high speed, low drag, that broken equipment just gets overlooked and equipment maintenance just gets overlooked. And that's how we wind up now injuring ourselves, injuring our patients, and really winding up not taking our duty to act, our duty to self, our duty to partner, our duty to patient as paramount as it is. So there are some protections for you if you are operating as help on your time off. If you are not currently working and not on the clock, you will be covered by what is known as the Good Samaritan laws. They were enacted in California in 1959, and it's something to protect you in the event that you do decide to start CPR in the aisle 2 of the market basket. If you're not being paid, it doesn't prevent you from being sued. It just means the lawsuit will be dismissed. Now, people can sue for anything that they want. They can file a lawsuit and we'll head off to court. But if you weren't on the clock, these laws will protect you from any type of litigation being successful against you. What that means is if you do decide to help and there's a negative outcome, say you are working a cardiac arrest in the aisle 2 of the market basket here in Chelsea, and you're doing compressions and getting the AED going and getting 911 on the way, and the ambulance shows up and you pass off your patient and the patient winds up not making it. That's just the nature of the beast. Out of hospital cardiac arrests don't have a very high save percentage, and the Good Samaritan law will protect you from any type of negative repercussions as long as you were doing things that you know you should have been doing. Now, if somebody collapses aisle 2 in the market basket in Chelsea in front of you, and you decide to try something new and fantastic that you saw on an episode of Chicago Hope, and you start doing cut down tracheostomies there with a knife that you stole from the kitchen goods section and some rubbing alcohol that you got from the health and beauty aisle, you're probably going to be in the soup a little bit. It all has to do with just staying and doing the things that you know that you're supposed to do when you're supposed to do them, and everything will go along swimmingly.
If you do have a lawsuit come against you while you're doing like a Good Samaritan, do you have to stop practicing until that's gone, or can you still, because lawsuits can take like a while?
No, you can still practice. One of the things that we'll talk about here in just a couple minutes when we get into negligence is exactly how long someone has to file suit, and that will lead us into documentation right nicely. But no, you can still practice. You're not going to be out of work because you're named in a lawsuit. So there's a couple other things that will offer some protection, but not a whole lot. Sovereign immunity, and a lot of these couple of things are just going to be straight definitions. So sovereign immunity, they call it governmental immunity. It prevents someone who's being treated by a government-operated EMS service from suing the government for civil liability. So places like Cataldo, we don't have that. We're a private entity. We're a for-profit business. We are not, fire department, City of Wakefield, or Everett, or Plainville, or anywhere else. So sovereign immunity doesn't protect us and won't protect you. If you're operating as part of a local, state, county, some sort of municipal EMS bureau, there is some protection there, but it is not absolute. A lot of these things still don't protect you from, what we're going to talk about as negligence in just a little bit. The statute of limitations for bringing suit in a medical malpractice negligence lawsuit is 7 years. Can anybody out there on Go to Training remember what they were doing at this time on this date 7 years ago?
Negative.
Yeah, I don't really remember what I did this weekend. The only reason I remember what I did yesterday is because I met all you nice people. So the statute of limitations being 7 years, there's only one thing that protects us from forgetting where we were and what we were doing 7 years ago. And what do you think that is?
Doing your reports.
Yeah. Doing your reports and having it be logical and concise and to the point, and more importantly, accurate. A well-written patient care report will get you pulled right out of being named as a plaintiff in a lawsuit. Because if you write your report well and put down and document everything that you see, everything that you did, everything that the patient said in your report, it makes you next to bulletproof. This is why I did what I did. This is why I didn't do what I didn't do. This is what the patient looked like. This is how I found the patient. And a lot of the times we wind up with this next little tidbit of information here. Contributory negligence. Anybody remember seeing that in the textbook?
I have.
Yes.
All right. And what did they tell you about contributory negligence?
It's when you don't do what you can to save the life, as in like you're not doing patient care reports correctly, you didn't take every step to try to save the life.
So that's more just regular negligence, and that's what we're going to talk about here in just a little bit. But contributory negligence is actually something that saves you. If we're on the sidewalk dealing with a patient, and the patient's saying, no, I don't want to go to the emergency room, and we're trying to convince them, and the patient goes, you know what, I'm out of here, and steps off the sidewalk and gets smoked by an MBTA bus. Am I responsible for that, or did the patient contribute to that negligent problem.
The patient contributed to it?
Yeah, so if the patient contributes to their own negligent behavior, you don't have to own it. We can't stop them from doing the things that they want to do. We're not, we're not police. We're not going to sit there and restrain people. And if you want to go, go, right? It's not my job to fight with people. So if the patient is found to be guilty of contributory negligence to whatever caused their negative outcome, you don't have to eat it, which is a nice place to be because people contribute to their own negligence all the time. We will find people, and when we talk about refusal in just a little bit, you'll see that people can, as long as they are conscious, alert, and oriented and meet a couple other specific categories, we can't force them to go to the emergency room. We may know good and well that 10 minutes after we leave, they're going to die. But there is not one blessed thing we can do to armbar them into going to the emergency room if they don't want to go when they're still conscious and alert and capable of making an informed decision.
But what if that does happen? So say we leave a person that didn't want to come with us to the ER, and then once we leave, they die. We get called back to the scene. How do you like work through that problem? Isn't that like a contradiction a little bit?
So a lot of that's going to be experience in report writing. And a lot of that is just the things that you say to the patient when you're trying to get them to not refuse care. And we'll get to that for sure. But one of the big things we always need to say to them is, all right, you do realize that, what I think you have going on for a problem could lead to some pretty negative outcomes for you, up to and including your death. But you're still telling me you don't want to go to the emergency room. I can't force you to go, but what I can do is tell you that you can always call 911 again. We're going to leave you in the care of a family member. We're going to have some responsible party sit here and stay with you and try to convince you to go to the emergency room. And then, especially if I thought the patient was that sick, I would probably wait in their driveway. And then when they went into cardiac arrest, I'd just go back in the house. Because there are some stopping points to where their refusal doesn't hold water anymore. I have a friend who did just that. He knew he was a paramedic. He had a patient on a cardiac monitor. The patient was adamantly and vehemently refusing to go to the emergency room. I'm not going, I'm not going. And they finally, after a lot of back and forth, took a refusal. Didn't want to, but had to because the patient couldn't be forced to go. And they waited outside this gentleman's house. And when he went into cardiac arrest, the wife came outside. They went back inside. And they didn't own any piece of that because they did everything that they were supposed to. They documented accordingly. And sometimes there's no saving people from themselves.
While I understand that, what happens if it's the family member of a patient that's in the way?
So give me a little bit more. What do you mean if the family member is in the way?
So let's say that same circumstance, you leave out, and then as they go into cardiac arrest, the family members, because they denied you, the family member still doesn't want to let you inside.
Oh, I'll have the cops take care of that.
Oh, fair dues.
Yeah, like I said, as much as in a past life, but my portion of this is not law enforcement, so the cops can deal with that, and I'll just go back in and deal with the patient because my duty isn't to the family member who's being a jerk. My duty is to the patient who's, on the floor dead and probably had other plans for the day. So here we go. We're going to get into the meat and potatoes of how it is that we actually provide care. Because we are not licensed, we are certified. In the state of Massachusetts, EMT is a certification, it is not a licensure. So we work under the medical license of a doctor. Here at Cataldo Ambulance, it's Dr. Schoenfeld, he's from the BI, and he provides for us all of our medical direction. He provides sign-offs for our protocols. I work at his leisure. If he decided tomorrow he didn't like me, well, I would probably be unemployed. It looked like somebody just raised their hand.
That was my fault. Sorry.
Oh, no problem. I just saw it pop up on the screen and I saw something shiny and it drew my attention. So our medical direction comes in a couple of different forms. First and foremost, we have our Massachusetts statewide treatment protocols. Those are what tells us that in any given circumstance, this is what we are supposed to do. It's what allows us to assist patients with medication. It's what allows us to deliver medication without having to pick up the telephone and speak to anyone. Because believe it or not, there's several medications that you're just going to be able to either give to or assist your patient with. And the only thing that you have to do is pass an EMT class and pass the National Registry exam. And you will be carte blanche to do that as long as your patient meets the protocol. You know, we have to do things like complete an assessment and take their vital signs and make sure that they sort of fit the typical patient presentation of the person who needs this medicine, and then we can give it to them. That's what's known as offline medical direction or standing orders. Those standing orders are protocol driven for us to just be able to treat people without having to pick up the phone and be, you know, a go-between for an emergency room doc and this patient. We assess the patient, we decide we decide within reason what's going on with them, and we provide care up to our level of training. And then there is another type of medical direction. Does anybody remember from the reading what that is? We have our standing orders, our offline medical direction, protocol driven. What do you think the other type of medical direction we receive might be is?
Oh, would they be do not resuscitate or the standing medical? Basically, the if someone's comatose, they have set out plans made by physicians in advance.
So yeah, that's going to be our advanced directives, and realistically, that's kind of like an offline because we have that paperwork there in front of us, and it tells us what we should and shouldn't be doing. The other part of medical direction is online medical control. Our online medical control, online medical direction is going to be when, yes, we actually do physically pick up a telephone or a radio and all but say, hey, doc, we are in muddy waters and this patient has XYZ problem. We have done this, we have done that, and now we are at a complete loss. And the medical control physician, the medical direction, will give you specific orders based on what you tell them and what the patient presentation is, and they will give you online medical direction. That online medical direction is just that. You are on the line, physically speaking, with the doctor who is really at that point assuming care for this patient. Now, a couple of things about that online medical direction. Do you think that the head of the emergency room for the BI West Campus ER is generally the person answering that telephone call?
Probably not.
No.
Yeah, not so much. Yeah, presidents of the hospital don't wind up answering the medical control phone. Generally, it is a resident. It is a new doc, or what we affectionately call doclings or baby docs. Not to their faces because they'd be mad. So they don't always know when you tell them you're a BLS ambulance or when you tell them that you are a basic level provider. They're not always 100% sure what our protocols might be. So they may give you an order that you are absolutely not trained to carry out or have no actual ability to do. Well, what in God's good name do you do then?
You don't do it. You say, you ask for like, is there something else we can do instead that like I'm able to do?
Yeah, it takes a bit more conversation at that point. Because if you remind them generally that you're a BLS level ambulance and it is out of your scope of practice to start IVs or do emergency cesarean sections or, you know, do intubations, they go, oh yeah, that's right. Sorry, you said you were a BLS ambulance. Transport this patient rapidly to the closest appropriate emergency room. We'll be waiting. You know, it is just one of those things where communication is key. If they give you an order and it's not an order that you can carry out, we don't just ignore it because we called and they told us to do something. But we have to make sure everybody is on the same page and playing from the same playbook, because there is no protocol for EMTs, paramedics, or anyone who's not a doctor to do an emergency C-section on the side of the road. That's just not a thing. There was an instance not too long ago in the city of Somerville where a gentleman was stuck underneath a train, and they had done everything but move heaven and earth to try and get this train off of the patient, and he was still pinned. And when our paramedics called medical control, what do you think medical control told them to do?
Probably not
Wait
to.
until the person is unpinned from the train.
Well, that's the logical thing, don't you think? Wait until they get them unpinned and then transport?
Yeah.
Okay, good. I like where your head went. Actually, what medical control told them to do was to complete a field amputation and transport this patient to a trauma center.
A field amputation of what?
Of the leg, yeah, the patient's leg was pinned. They told them to cut the guy's leg off and get him out from under the train.
Was this the
Oh my
rail train
God.
that you're talking about? The incident that happened like 3 months ago?
I think it was a little longer than 3 months, but you could be right. Yeah.
So is that
Did
out
they
of
do
our
it?
is that out of our scope of practice though to
Oh, by
amputate
a lot.
the
Yeah.
limb?
First of all, on a regular ambulance, they don't carry enough drugs to even make that plausible. Just, you know, if you think about, you have a patient conscious and alert, and we don't have enough drugs to medicate them. And then my next question would have been, what exactly would you like me to saw this person's leg off with? Because it's not like I'm a construction worker and I can just crank up the Sawzall and make sure it's got a fresh battery and we're off and running.
So
So
don't you have to meet the fire department in order to get a proper saw or something? Because wouldn't that, I think that'd be the closest thing I could think of.
I would have thought that they would have had like doctors come from the hospital to
there you go. And that
do
would
it.
have been my out, to be perfectly honest with you. Hey, doc, listen, that's way outside of our scope of practice, way outside of protocol. If somebody's gonna cut this gentleman's leg off, somebody ought to get into a vehicle down at the BI and start heading my direction, because we just incapable of actually accomplishing that. Not to mention the fact that it's so far outside of protocol and everything else. Like, how would you actually like me to do this? And I'm sure once they said, well, the fire department's got saws, it probably would have dawned on this doc that, like, hey, you know what? That sounds crazy, because it was crazy.
Now, has there ever been a situation where you're getting feedback from one of the doctors or something, and they're telling you to do something outside of your scope of practice? You tell them that it is outside of your scope of practice, and they seem to like get upset or pin the blame on you for not doing what they expected you to do?
Nope, because there's really no blame to be had, right? We're not calling them because something bad happened and we're looking for them to bail us out. We're calling them
Right.
because we have run out of logical things at the BLS level that we can actually do and accomplish. And something's got to give. So we get on the phone with medical direction, because our protocols don't really, they are not all encompassing, right? And they are not written in stone. So if you have a question as to whether or not the treatment that you're leaning towards or away from is right or wrong, then absolutely pick up the phone and have a conversation. That's what they're there for. But
Okay.
you've heard me say emergency cesarean section a couple of times.
Yeah.
So a few years back, there was paramedics, I believe it was in New York, where they arrived on scene of a motor vehicle collision. Motor vehicle collision was a pregnant female driver. Said pregnant female driver was dead on scene, and she was, you know, like ready to deliver pregnant. And they picked up the phone and called medical control for some advice, because I don't know if she was pinned or what the exact story was. And their medical direction told them to perform an emergency C-section and transport as soon as possible. And they did. And everyone died.
The
And
baby died?
everyone got, the baby was dead already.
Oh.
And everyone got fired.
Was the baby dead from like the lack of oxygen and like the blood circulating in the
Yeah.
body and everything? Okay.
Yep. There was no happy ending to this story, because they did something that was way outside of their scope of practice because medical direction told them to. And even knowing that it was outside of their scope of practice, they did it anyway. And everybody wound up with some egg on their face behind that. So if you are ordered to do something that you know to be outside of the realm of what it is okay for you to do, so really anything not contained in that textbook or that you haven't been appropriately and adequately trained to do after class, you just can't do it. Period. End of story. Regardless of what the doc tells you, they're gonna get some repercussion from it too, but let them be the one that has all the repercussion. Don't do things that when somebody tells you to do them, they sound absolutely bonkers, because there's no protection from doing something that when you step back and go, yeah, that was kind of nuts, wasn't it? Not a good look. So moving on, we're going to talk about ethics and morals and code of ethics for the National Registry, and all that is really good stuff. Now, everybody pretty much, when we went around the room, passed the ethics and the code of ethics challenge when we were introducing ourselves and talking about who you are and why you decided to do this as a career. Ethics is just a study of morals, and morals are your concept of right and wrong. It is just how you carry yourself and how you will actually perform your duties as an EMT and live your life as a person. Now, try as I might, it is absolutely impossible for me to teach people to be moral and ethical human beings. You either are or you aren't, and that's completely on you as a person. But there is a code of ethics for EMTs. The National Registry came up with it in 1978, and what it really says is, as long as you are doing what you know to be right and caring for the welfare of your patient above all else save for your and your partner's safety, you are completing the job and doing the things that are supposed to be done. There is very few unethical, immoral things that I could come up with in my 20 years of service that I've seen providers do. Most people don't get up and throw their EMT uniform on and go, you know what, I can't wait to be a jerk and treat everybody like crap today and just be immoral and unethical and just do everything wrong. It doesn't make sense. You don't get into a job dealing with the public and trying to help people and have that be your MO. You guys all said all the right things yesterday and didn't even know it. All right, let's see. I have 9:30. You've all been on and staring at your computers for almost an hour. So here's where we get to our first break. You guys will see that just about every hour we take a break, because after an hour of just listening to me babble, nobody's paying any more attention until they get up and stretch and move around a little. So I am going to put 12 minutes on the timer, and in 12 minutes we will continue our discussion about patient consent and refusal. All right, everybody, we are back and ready to get moving. Everybody back from break?
Yes.
Mhm.
Good deal.
Yep.
Now we're going to talk consent and refusal. Patient consent is something we get on every single patient for every single transport. And there are very few cases where we don't actually need consent from our patient to provide care and treatment and transport. Informed consent and expressed consent are sort of like two sides to the same coin. Informed consent means we are going to speak to our patient and talk to them about all the associated risks and consequences with what we think is going on with them and what we would like to do for them, to them, and going down. From there, they will express their consent. They will say, yes, you know what? I think you're right, or I think I do need that treatment, that care, whatever. And they will say, yes, please treat me, please take me to the emergency room. Now, it doesn't necessarily go down like that on every single call where, you know, right to the letter, we say all of those words and we do all of those things. Something as simple as, hey, my name's Tommy. I'm an EMT here with Cataldo. It seems like you're having some chest pain today. Do you mind if I take a look? What do you think the patient's going to say to me?
Either yes or no.
They're either going to say yes or no. If they say no, we have to get into a bit more of that informed consent. I have to talk to them about all of the things and the reasons and the whys and what fors. And then we still try to work towards them expressing, yes, I would like you to treat me. I would like you to take me to the emergency room. If they say no and they continue to say no, we'll talk about refusals in just a few minutes. What do you think this implied consent means?
It's when they're not able to tell you yes or no. Like, let's say if they're like having like a seizure or something,
Bingo.
or they're unconscious.
Yep. We use implied consent when someone is not able to actually express to us their consent for treatment. And again, we base it on rational and reasonable. If we show up like this gentleman here that's on the sidewalk, I can assure you, just based on the medication that is being taken out of that bag, that he is unresponsive, and we operate on implied consent to treat these patients based on what a reasonable, competent, and rational human being would want us to do. He would not wish for us to just leave him laying on the sidewalk, unresponsive, and really all but dying. He would really probably like for us to treat him and wake him up and bring him to the emergency room. So we operate under implied consent to do that. What's your question?
Does that still imply of like, so like 5 minutes later, they're like, no, I don't want to be treated. And then a minute later, obviously he goes unconscious. There's obviously an issue. Can we work on implied consent then, even though about 30 seconds before they're like, no, don't touch me?
Absolutely. The minute they go unresponsive, we click right into implied consent and we start providing care.
Okay.
It also happens the other way around too. Like if they wake up, and then that's when you have to inform consent.
It does indeed. If we wake them up, it happens a lot with, say, drug overdoses and diabetics, as a matter of fact. If the patient wakes up and all of a sudden withdraws their consent, there's very little we can do to actually force them to go to the emergency room. I'm going to teach you some salty old tricks how to get around that, because treating and releasing a patient is just bad medicine. But that's not a today conversation.
What, like the cops?
No, not even the cops. Easier than that. I don't wake people up in the street. I don't wake people up in their houses. I wake them up in my ambulance when we're moving.
Yeah.
What about if
like kidnapping and one of the sections in the textbook?
Yeah, because once they remove their consent, if we drag them away, against their will, we have not only kidnapped them, we have probably assaulted and battered them at the exact same time.
What would happen if they started to take away consent, but you were like in the middle, like say you were middle splinting his ankle? Do you just start taking off everything then?
For the most part, yes.
Okay.
But yeah, we'll just operate under yes for that for now. A lot of, like I said, a lot of this you can get by that initial, "Oh, I don't want to go to the emergency room." Yeah, well, no kidding. Nobody wants to go to the emergency room. You're going to sit there for hours on end and wait to be seen, and you're already having a miserable day. I get it. But once we start getting into the, hey, this is what could happen to you if you don't get that ankle fracture looked at, up to and including, you could lose your foot, you could die. People start to come around a little bit and realize that, being one-legged or being dead really isn't the option when it's only a couple hours out of my day. When we talk about consent to treat a minor, minors are a bit of an outlier for us, right? Because it's difficult to obtain consent from a minor patient because they are not of age to actually consent to anything. So what gives us the right to actually, if we show up to a playground and there's no adults around, to treat little Susie in her broken arm?
Isn't it significant threat?
So it doesn't even really have to be significant threat. It's right back to that whole, what would a reasonable parent or reasonable guardian wish for us to do? Would they
Probably
want us,
kidnapping.
they wouldn't want us to leave her laying there in the playground while we were trying to either track somebody down or just say, all right, well, since there's no adults around, I guess we can't bring Susie to the emergency room. That's
If
kind
there
of
is no adult around, isn't that kind of child neglect? Because the parents like nowhere around.
kids go out and play by themselves all the time. Depends on what age. If it's a 2-year-old, at the basketball court behind our building here all by themselves, that's maybe a different story. But if we're talking 10, 11, 12, 13, just out hooping it up at the playground, no big deal.
Mm-hmm.
The other ways we can obtain consent to treat a minor is from school. When a kid goes into school, they are under the care and basically custody and control of the school administration. So
Yes, sir.
teachers, principals, school nurses, they can all actually provide consent for us to treat and transport the child in the absence of a parent.
And that one was the in loco parentis, right?
Yes.
And then the other one's the emancipated minors.
We'll get into a lot of the emancipated minors and 17-year-olds that are signed up for the military or pregnancy and that kind of thing when we talk about refusal, because there's all sorts of little landmines that are just waiting for us to step on them when we start talking about refusal. The question was posed to me, how often do you take a refusal? And my answer to that is I absolutely never try and take a refusal from a patient. I would so much rather, go over the top and tell you 25 different ways that your problem could kill you than take a refusal from you and wind up sort of in the wind with that. It's way easier to just bring people to the emergency room.
Yeah.
And this last one that we're going to talk about here is involuntary consent. Involuntary consent in the state of Massachusetts means you are transporting someone by court order, and it is because that they have been deemed as a threat to themselves or to others under Massachusetts Section 12. You'll hear it referred to as just a Section 12, or you will hear it referred to sometimes as a pink paper, because the copy, it used to have to be live signed and it was a pink form. And that means someone has been deemed mentally incompetent to make their own decision at this very given moment in time and proven to be a danger to themselves or to other people. And we can transport them involuntarily against their will. But that is the absolute only time we are allowed to do that. That Section 12 paperwork can be filled out by a police officer, or it has to be filled out by a licensed medical professional, something like a psychiatrist or an MD, someone who has seen and evaluated this patient and deemed them at risk of harming themselves or other people. And it's generally about a 72-hour hold, and it could be longer. Sometimes it's shorter. It's very much the gray area that we live in. But really, involuntary consent is not really altogether that consenting most of the time.
Also prisoners, right?
Prisoners have a different kind of sort of involuntary. Just speaking from past experience, I worked in the medical department in a prison. Their ability to refuse is pretty much revoked from the point of incarceration on, because the jail, prison, whatever it is that they're being held at, are the ones that are now responsible for their care and treatment. So it's up to the medical staff at the facility to decide what they need, when they need it, and how they need to get it.
Now,
When
with
we
that,
when we
sorry.
are using involuntary consent, will we always have a police officer around, say like he is a danger to others himself and he doesn't want to come with us? Like we don't have like handcuffs, so he doesn't attack us.
Right. We'll talk about restraint a little bit. For the most part, no. If a patient is under arrest and going to be in hard restraints like handcuffs, there always needs to be a police officer in the ambulance. But as far as the whole safety aspect of that goes, if your patient is so out of control that you think that there's a risk of an altercation between the two of you, then yes, absolutely, you get the police officer to go with you. But for the most part, people view us as a little less threatening on most occasions. And when their option is go to jail or go to the emergency room, generally it's go to the emergency room. And the other portion of that is, it's not your job to tackle them and fight with them and roll around on the floor of the ambulance to get them to do what it is that they're supposed to be doing. So if they are that out of control and they're like, you know what, I'm not going, I'm getting out, yell up front, have your partner stop the truck and say, have a nice day. And then call the police.
If they're in handcuffs when we arrive on scene, does that still mean that they're incarcerated, where now it's the cops' duty to make decisions on their well-being? Like, can they at that moment, like, let's say we don't have someone come in the ambulance with us, like a cop come in the ambulance with us, and the patient halfway through the ride decides, yeah, I'm not doing this anymore, and tries to get out. Like, what? I don't even know how to ask the question. Like, in that moment, is it even up to them anymore? Or because they were incarcerated to begin with, they, like, at that moment, they were either headed to jail or the emergency room?
So if they're under arrest, they can still refuse treatment. They can still refuse to be brought to the emergency room. And then at that point, they go in the blue vehicle instead of the orange and white one. If they're under arrest and in hard restraint, they will never be in the back of your ambulance without a police officer. There's just a period at the end of that, because we don't have the ability to unhandcuff them if something goes wrong. So yeah, if they're in handcuffs, there's a cop in the truck with you. If they're we'll say quasi-voluntary going to the emergency room to avoid going to jail, all right, you can get out. I'll just let you know that I'm going to call the cops and they're going to come and arrest you. Or you could just go to the emergency room and act like a human. And most of the time, they would much prefer to go to the emergency room than to go to jail.
Okay.
So next, we're getting into our advanced directives. Now, somebody mentioned do not resuscitate orders and all of that stuff, and that's what we're going to talk about now. A do not resuscitate order is a bit of the old terminology. We used to have this form called the DNR. It is not as common now. What we see a lot of the time is a form called the MOST form here in Massachusetts. It's just like that bottom bullet point, the POST form, but instead of physician, the P, we have Massachusetts Medical, so it's a MOST form, I guess you'd say. The do not resuscitate order and the MOST form provide us with information on what our patient's wishes were should they either go into cardiac arrest or have some form of major medical event. Now, what those two forms never say is do not treat. You know, we treat people when they call 911. What these forms really were designed for and what they were really made for is for people that know they are at the end of their life and their time is beginning to dwindle. These folks make decisions ahead of time so that we don't show up in the ambulance and start doing CPR on someone who is stage 4 terminal cancer and on hospice, who has no quality of life left, knows that they will not survive a cardiac event. And if they do, it's just going to make things worse. So the form that we use now is called a MOST form, and it is right here in front of you. And what you'll see is it's a bit of a menu. They can actually choose, do they want to be resuscitated? Do they not want to be resuscitated? Do they want to be intubated and ventilated? Do they not want to be intubated and ventilated? And they can pick from each of the categories. They can say that they don't want to be transferred to the hospital unless it's needed for comfort. These are things like our hospice patients who, you know, need to go to the emergency room for some pain management or something like that. It's really just on you to look at this form when it's presented to you. And once it is, follow the wishes on this form because this is what the patient wanted. Now, if there is ever any doubt as to whether or not this form is valid or legitimate, or patient's family said, no, just before they went unconscious, they said that they wanted to be saved and we needed to call 911. What do you think you should do?
If the form
Should you
says
verify with like a doctor or something?
Gonna be hard to get their doctor on the phone at dark 100 in the morning when they called 911, right?
Right.
so you don't, if there's a form that proves with a physician's signature, then you still do not resuscitate because even if it was verbal, you weren't there to see it. So technically, you have to follow what the paper says.
Actually, it's the opposite. If there's
Yeah.
ever any question about the validity of this form or whether or not the patient revoked it just before the end, we would actually commence with providing care and treatment up to our level of certification. So if they're in cardiac arrest, we would manage a cardiac arrest. If they are in respiratory arrest, we would ventilate them with a BVM, bag valve mask, and do all of the things that we know that we're supposed to do. Because the theory behind it is, if they're dead forever. A couple of minutes while we work on them and bring them to the emergency room and the doctors figure out what's going to be done doesn't hurt us one bit. But if we don't do anything and they really had rescinded the order, because the patient can revoke this at any time. So if there's ever any question, treat the patient, bring them to the emergency room and let somebody who makes a whole lot more money and has a whole lot better insurance than you make the decision.
But if, like, let's say we did that and a family member had lied and the person, comes back to life, but now they're like, well, I have a DNR form signed. Like, now they want to press charges against you for not following the DNR request. Like, what happens then?
Documentation is going to be what's the most important. The way you document that whole interaction with the family and everyone around is going to be what saves you. Because if you don't write down that, on our arrival, patient's family met us at the door and told us, Nana's not breathing, she doesn't have a heartbeat, but she told us she wanted to be saved, she needed us to call 911. If you don't write all that in your report, it didn't happen. But if it goes in your report, you have something to stand behind. We started working this cardiac arrest even in the presence of a MOLST order that said do not resuscitate, because the family informed us that the patient rescinded that prior to going into cardiac arrest.
How close does the family member have to be? Like, say the wife says it follow the MOLST form, don't resuscitate, and then the daughter is like, no, resuscitate, he wanted it, or I want it.
Luckily, that's not for us to decide. You let them hammer it out while you're taking care of the patient. We don't run into those situations a whole awful lot. And there's no like, do this, don't do that type of answer to it. We have to do the things that we know that we need to do. And a lot of times just explaining that to the family is, listen, we need to come up with something right now, because one of you is saying he wanted us to come help. One of you is saying he didn't want us to come help. We have this form saying he didn't want us to come help. We're going to go help while you two hash this out, and we'll figure out the details a little bit later on. But right now, we need to go get on about our business. And thankfully, there's normally enough people on scene that that whole problem can be elsewhere while we're doing our thing. But most of the time, when this form is present, the form is pretty much taken to heart.
I have a question.
Okay.
Let's say we get a call from a nursing home or retirement, say that there's someone having difficulty breathing, and this person has a DNR, but we're not aware of the DNR. And the staff were just like, oh yeah, this person's having trouble breathing. How do we ask if they have a DNR? Oh, I know once we answer the 911 call, we have to act right away.
So a DNR is only going to come into play when they're actually in cardiac arrest anyhow. So difficulty breathing, it really wouldn't make that much of a difference to us. But especially in a nursing home, they'll generally have all the requisite paperwork pretty much ready to go. You just ask.
Oh, okay. Thank you.
Sure. So this is how we determine whether somebody is competent to refuse treatment. Like I told you, refusals are a big deal. First and foremost, the patient must be lucid and capable of making an informed decision. So that is the fancy way of saying competent. They have to be conscious, alert, and oriented, which is the 4 questions you're going to see right over here. We're going to ask them, do they know who they are? Do they know where they are? Within reason, do they know about what time of day it is? And do they know what is going on? If they are altered in any way, shape, or form, whether it is by their medical condition or by something like a head injury or drugs and alcohol, like 3 and 4, they are not able to refuse treatment. If they pass our conscious, alert, and oriented check and we find no signs of any altered level of consciousness, we'll move on down to section 2 of all this. And this is pretty much for us. Do we feel like they need medical treatment and evaluation? The answer to that's always going to be yes. Do we feel like they need ambulance transport? The answer to that is always going to be yes. Do we feel like further harm could result without medical treatment or evaluation? Guess what? The answer to that is always going to be yes. And we move right on down this sheet until we get to patient provided with refusal information sheet. Now that refusal information sheet is going to carry things like the telephone number to local emergency services, maybe the Cataldo phone number. It's going to tell them that they can call 911 at any time and we will come back and evaluate and treat and transport just like before. And then we have to document, did they accept all of this information? And then as we go down further, we have to get lots of information about the refusal. And we have to have a witness sign the form. The witness cannot be your partner. The witness should be a police officer, firefighter, someone on scene, hopefully with some rank in whatever it is that they're working as, either police, fire, or whoever, or even a patient family member, because what holds up better? Your partner saying that, oh yeah, that patient didn't want to go, or a captain on a fire department, or the patient's spouse saying, yeah, they did everything they could to try and get Frank to go to the emergency room, and he was just being stubborn and didn't want to go. It's always good to have someone who's a sort of, not really an objective third party, but maybe someone who doesn't have your best interest in mind. They have the patient's best interest in mind. I will go out of my way to let everybody in that room know that, all right, we're going to leave you here. It's against my wishes to leave you here. But what I'll tell you is, you're probably not coming down for breakfast in the morning if you don't go to the emergency room with us. Like, if you don't come with us and go get treated and evaluated, this problem that you are calling us for could absolutely result in your demise. Now, if that's a chance that you're willing to take, go ahead and sign this form. I'll be happy to come back anytime you call 911. But just know that it could be too late at that point, and you could already be beyond saving. The thicker you lay it on, and the deeper you sort of bury this patient with, hey, you could die. I just want to make sure you could die. Hey, listen, I'm going to go, but this could kill you. You just keep saying that. And if you're saying it enough and believing it enough, and you're saying it maybe in front of somebody that cares about this person, sooner rather than later, they're going to just cave and be like, oh God, if you'll shut up, I'll go to the emergency room. Perfect. That's what I was looking to hear. Come with me. And then we're out of there before the patient can change their mind. Because we need to protect ourselves for real when it comes to patient refusal. Try anything and everything, lie, cheat, steal, beg, borrow, I don't care. Do whatever you can to get this patient to just go to the emergency room. It is easier for all parties involved.
What if they were alert but it was really delayed? Like you ask a question and it takes them a full minute to respond, but the response is correct.
It's going to depend on if that's their baseline,
Okay.
or if it is some new form of altered mental status.
Yeah.
If they just, old people sometimes have to think about things like that. It's just a product of aging that they don't respond as quickly to questions. If that's their normal, then there's not much we can do. If that's a new development for them, we still treat that as an altered mental status.
Okay. How do you know if that is their baseline, though? If this is the first time you're meeting this person?
Generally, someone on scene, especially for a medical call, will have some sort of insight into the patient. And when all else fails, guess what we can do?
What?
We can pick up the phone and call medical control and let the patient talk to medical control and let the doctor make the decision with them.
Okay.
Because I really don't like being the person on the hook for a patient who's trying to refuse treatment that I'm uncomfortable with. Because I didn't get into this job just to leave people in their living room and let them pass away from either misinformation or stubbornness. But at the end of the day, I know it's not my job to go dragging them around the city of Malden to the emergency room when they don't want to. This is the important one. This encouraged the patient to seek help later. Let them know that refusing care now is not refusing care forever. They can change their mind and we'll be happy to come back. And then document everything very, very carefully. It takes way longer to document a patient refusal than it does to actually just bring someone to the emergency room and write up a patient care report for someone you actually did things for. So the last little bit we're going to get into here is we're going to talk about negligence. And when there's negligence, these are some of the things, some of the words that you need to be familiar with. Very infrequently does criminal liability come up to rear its ugly head with EMTs. This is actually being charged with a crime that could result in a fine or jail time or probation or something like that in your commission of your duty as an EMT. Now, I can't think in 20 years of any situation where I did or was in a position to have to do anything that would have resulted in my arrest in the back of an ambulance. It's just not something that normally happens. You know, if you get mad and beat your patient near to death or something like that, guess what? You're going to go to jail. There's your criminal liability. Civil action is generally what winds up happening with negligence when we talk about committing the duties of an EMT. You will be named as a plaintiff. Sorry, not a plaintiff. You will be named as a defendant in a lawsuit. The plaintiff is the patient. The plaintiff is the person who files the lawsuit and says, they did something negligent and I had problems as a result of it. They'll get on the phone with Jim Sokolov, and you will be named as the defendant in a civil lawsuit before lunchtime. That civil lawsuit is a tort. And what they are charging you with is negligence. Now, in order for negligence to have been proven, these are some of the things that need to have happened. So everybody's familiar with what their duty to act is, right? When you're here at work and you're a certified EMT, your job is to provide care to your patient. You have a duty to respond. You have a duty to act and provide care. Now, that doesn't mean in unsafe situations you just go rushing in and get shot by a crazy person. Your duty to act for yourself comes first, but that also means that you just don't go, all right, well, I don't feel like responding to this 911 call, and stay in the base. So your duty to act is just that. The next thing that they need to prove is that you breached your duty to act. So you were supposed to do something. You were legally obligated to act and react in this situation, and you didn't do it. The third piece of negligence is from your breach of duty to act, the patient suffered some sort of harm. So think of all the things that in failing to do your duty could cause a patient harm. They're innumerable. So there's plenty of opportunity here for, if you decide not to do the things that you know you're supposed to do, that your patient will suffer some sort of injury. And that's not even enough, because they have to prove all four of these things. The fourth one is they have to prove that those injuries were the result of your breach of duty. So it isn't just that you had a duty to act and you didn't do anything and the patient suffered some sort of harm. That harm has to be directly attributed to your breach of duty. So it's a pretty easy connect the dots if you don't do the things you're supposed to, but negligence isn't really a layup as long as you are actually doing all the things that you know you need to do when you're at work, working in an ambulance, providing care as an EMT. And the last part of this is patient abandonment. When do you think it's okay to leave your patient?
Never.
Never.
Well, then I'd still be at the emergency room at the Winchester Hospital from almost 20 years ago.
Only well, maybe when you pass them off to like the nurse or doctors that are there.
Bingo. You are not free from your duty to act as a provider for this patient until you have passed on care to someone of equal or higher training. That means we don't just dump people in beds in the emergency room. We don't just leave people with the janitor or anything like that. Until you have actually physically handed off care of this patient to someone else of an equal or higher training, you are still obligated to be right there with that patient until someone comes along. So abandonment is just leaving your patient without actually passing off their care to someone. Now, when we talk about just things like routine transfers and things like that, there are times where we do bring patients to doctor's appointments. And maybe we do put them in a wheelchair or put them in a bed at the doctor's office. And maybe we don't hang around for them. Why is that okay?
That's not okay, right? Because you have to make sure that the doctor gets like a full report of what's going on.
Perfect. Then it's okay. As soon as we say, hey, this is John Smith, he's here for his appointment with Dr. So-and-so, and they accept that patient as being there for their appointment, we're good. We have now transferred care of that patient, and the doctor is aware that that patient is there for their appointment. We are well in the clear to be on our way. But when you get to the emergency room and you are emergently taking care of someone, you have to make sure a handoff is done. So that way people don't wind up in a bed in the emergency room and nobody knows that they're there. Because that would absolutely be patient abandonment, and that would be a real for life, big time problem. All right, that was chapter 3, folks. What do you think?
It was
It
pretty
wasn't
informative.
that bad.
Everybody good with the pace and all that?
Yes.
Yeah.
Yeah, it went well.
Excuse me. All right. So before we get into chapter 4, we're going to take another short break, because you just can't sit there for 3.5 hours or 3 hours or whatever and listen to me babble for hours on end. So we're going to take 10 minutes, and when we come back, we will talk about communications, and that will carry us right up until about lunchtime. All right, everybody, welcome back. We are now going to get into lecture, chapter number 4, communications. We're going to talk about a little bit about sort of just interpersonal communications and how we talk to one another. But most of what this is going to center on is equipment more than anything else, because we're going to talk about the actual way we communicate with dispatch, the way we communicate with other providers, the way we communicate with online medical direction, and it is all pretty much still done by radio. There are some fail safes that we can fall back into when the radios aren't working, but we'll talk about why that's a little bit of a pain in the neck for all parties involved. First things first, we have a base station. Base stations are just what they sound like. It is a giant fixed antenna, generally at wherever the radio frequency is leaving from. So think like the Cataldo ambulance base, 25 Eastern Ave here in Malden. It puts out a high-powered 80 to 150 watt transmission through that antenna to send those radio waves out to the masses. That's how that radio wave gets to your little portable radio. That's how the radio wave gets to the mobile radio in your truck. It is initially sent out by the base station. Those base stations transmit that signal far and wide by using repeaters. Repeaters are just other antennas along the system that will amplify and kick that signal on further down the line, so that way when a signal leaves Malden, we can talk to our ambulances in Boston. We can talk to our ambulances probably almost as far away as places like Providence, Rhode Island. If we couldn't have those repeaters and we didn't have the ability to transmit that signal further, it would really kind of be limited to line of sight. You would only be able to send radio signal to and from places where you could see to. And that really doesn't do us a whole lot of good, because we have trucks in Boston that cannot see 25 Eastern Ave here in Malden, where their base station lives. And without repeaters, nobody would be able to talk to anybody, and nobody would have any idea where anybody was going, was supposed to be. And it turns into a big time kerfuffle from there. All of our radio communications are governed by the FCC. The FCC limits how much of a power level you can transmit with. The FCC actually governs and issues licenses and suspends licenses when people break the no-no rules, like swearing on the air and things like that. They can actually monitor our frequency and bust right in on the channel and say, hey, cut that out if they wanted to. They are the people that issue these radio licenses and control everything that we can and cannot do on the radio. Getting further on down, the further out we get from that base station, the lower power and the lower ability for transmission we have. Our ambulance radios are what's called mobile because, well, ambulances are mobile. They are mounted into a vehicle. They have a much lower power and a lower range than the base station. Our ambulance, as long as it is within 10 or 15 miles of a repeater, should be able to get a message out and then get it on down the line back to where we're trying to send it to, because it does us no good to send a message if it can't ever be received. So in order for your mobile radio to work, it has to be within 10 to 15 miles of a repeater. Now, that being said, things like terrains, or if you're way up high on a mountain or way down low in a ditch somewhere, it's going to affect how well your radio communication actually gets out and whether or not it makes it to those repeaters. I had a friend, a place where I used to dispatch, who his hobby, on top of being a dispatcher during the day, he was some sort of ham radio operator at night. And he was always constantly coming in, oh, I talked to somebody in Russia today. How on earth you make a radio signal go that far is absolutely beyond me, because what I know about radios is if I push the button and it doesn't work, I pick up my cell phone and call somebody. That's our fail-safe. If the radio's not working, cell phone it is, but that's not always the greatest. Next, we have our portable radios. These are called portable because they are person portable. They are for use outside of the vehicle. They have a very limited range. You have a hard time using these in places like elevators or hospitals, or really anything that's made out of solid structure like concrete or brick. The radio signal is actually going to be too weak to get any type of messaging out. And that can wind up being a bit problematic for us at times. But we're never out of communication, because we have digital equipment like a mobile data terminal that's some software that is actually on our Toughbook computers that we bring into our patients' residence with us. So as long as we can hop onto a Wi-Fi signal somewhere, we can get messages back and forth with the communication center. Because unless dispatch knows where you are kind of in a jam. If you needed help and nobody could find you and nobody had any clue where you were, guess what's not coming?
Help wouldn't be coming.
Help wouldn't be coming. And the time to figure out that you're in the soup and help's not coming is not when help isn't coming. You need to start thinking about things like this ahead of time and make sure that you are constantly updating the communication center like you're supposed to, and keeping in touch. And really, like, it's not only a safety consideration, but it's also a patient care consideration. Because as a dispatcher, I've called people on their phones like, hey, you've been on scene an awfully long time. Do you need further assistance? Do you need something else? Are you so busy with a sick patient that, you know, you couldn't get on the phone to ask for extra hands? So always keep in touch with your dispatcher and buy them junk food. They like that. And when all else fails, we have the ability now at a moment's notice to reach out and touch someone. We can call on our cell phone 24/7, 365 with relative reliability, and know that we will get in touch with whoever it is that we are looking for. What do you think some of the benefits to being able to have a cell phone on scene and have that instantaneous communication are?
You could call the doctor or whoever, like a further medical assistant right away, and they can tell you right away, okay, do this to her right leg and all that.
Yeah, it is absolute instantaneous. I pick up the phone, somebody is going to be on the other end of that. I don't have to wait for the radio waves to clear. I don't have to hope that that radio message gets out. I don't have to hope that I receive their message. As long as I have signal, we're in the game.
On your cell phone, if you call, should you be calling like dispatch or should you be calling like a medical professional? Like, what are some examples of people that we, could call off of a cell phone?
So medical control would be one. You can call them on your cell phone. When we're transporting someone to an emergency room, the emergency room wants us to call in an entry note, which is just letting them know who we are, what we have, and how long we're going to be. So that would be another time where we could use our cell phone. And then dispatch would be another one. If you're at the patient's side and your portable radio is not working and you need an advanced level ambulance to come and meet you, or if your patient is 700, 800, 900 pounds and you need additional hands to get them out of the house, you could pick up your cell phone and call, and they would send you anything you asked for at that point. So the advantages are just how quick and easy a cell phone makes it. Now let's talk some disadvantages. I want everybody to look at the woman on the phone on the phone here in this picture and notice what she has on her hands.
Phone.
She's got a phone in her hands, but what's on her hands?
Gloves
Gloves.
on.
Gloves.
There's gloves on her hands. You know why you have gloves on?
To protect yourself from bodily fluids.
Yeah, to keep things that are gross off of you. And she's got now her hands on her phone pressed against her face with those nasty gloves on. Blah, forget it. So first and foremost, just a little operational mindset here. If you're going to be touching something that belongs to you, probably don't touch it with gloves on, because you put gloves on to get crud on them. So don't go wiping that crud all over your face and all over your phone and all over all of your gear. So some of the disadvantages are, what happens if my phone gets broken on scene? Who owns that?
You?
I do. What happens if I get all sorts of schmutz all over my phone in a scene?
It's your responsibility. It's on you.
Covered in gross stuff. And then now let's talk about the time demand of a phone call, because Cataldo Ambulance has anywhere. I couldn't even actually, since I don't really work in operations, I couldn't tell you how many ambulances we have on the road right now. But I can tell you the amount of ambulances we have on the road far and away outnumber the amount of call takers and dispatchers we have in the communication center. So if all the ambulances decided they weren't going to use their radio and they were going to pick up the phone and call the communication center, they would be swamped in the first 2 minutes of phone calls. So the radio is far and away the more efficient way to communicate with your dispatcher and with the communication center. A disadvantage to the phone is that it ties those people up so that they can't answer all those other ambulances out there that are maybe requesting help or maybe need an advanced level provider to come and start an IV and push some medication so that their patient survives. The disadvantage to the phone is just that it just takes more people involved to actually accomplish the task. So, having been a communicator and somebody who worked in the communication center, these are a pretty decent list of the do's and don't do's when communicating on the radio. First of all, radio communications for most companies, police, fire, EMTs, are only one person talking at a time. So keep your conversation brief. I don't need news, weather, and sports when you call me on the radio. I know where I told you to go. I have a system that monitors that. All I need to do is know what you're doing now. All right, we're transporting. Thank you very much. Ambulance 42, I have you transporting. You have to make sure your radio is on the correct frequency, because if it's not on the Cataldo radio channel, you'll be talking to someone else. The next bullet point here, listen before transmitting, is probably the most important, because since only one person can use that frequency at a time, if I'm trying to say something and you key up your microphone, you just did what they call walked on me. And what that does is it jams up the radio frequency, so I think my transmission went out, and guess what it didn't do? It didn't go anywhere. Nobody heard it. So use your listening ears when you're getting ready to talk on the radio. The button on the radio that allows us to talk back and forth is called the push to talk button. After you press that button, wait a second. There's a bit of a delay. If you start actually talking the minute you squeeze the button on your radio, no one's going to hear the first few things that you have to say, and arguably those could be the most important, because it should tell me who you are. Because if I just hear a brief interlude of "we need help," but because you just started yammering the second you squeeze that button, I don't know who this "we" is or where that help is needed. So listen and pay attention, but don't start the second you press that button. Just give it a tick and you'll be able to talk. Bullet point number 4, speak with your lips about 2 or 3 inches from the microphone. 2 things: you do not need to yell into the radio, and you do not need to have the microphone essentially inside of your mouth in order for me to hear you. This 2 to 3 inches is important, because I can't understand a word you're saying if you're talking with your face right this close to the it's a mumble from there. There's absolutely no ability to make out what you're saying. And a lot of the rest of this is just follow sort of company protocol. You know, if you're supposed to identify your ambulance by name and number, do that. Cataldo Ambulance 42, pretty simple. When I respond to you, I'm either going to tell you to go ahead or stand by. If I'm telling you to stand by, that's because I have 14 other things going on at the moment, and your call is important to me. But we'll get back to you in the order that it was received. It's how things don't get missed. If it's really sort of just like regular radio ground rules for how to not mess things up 101. Because I understand, and especially if you're in an emergent situation, standby is not going to be acceptable. You go right ahead and roll your way right over that. But if you need to call me and tell me that you're transporting and I tell you to stand by, I'll get back to you. If you need to call me and tell me that you're being chased through the street by a crazy person with a knife, ignore my standby and say, hey, ambulance 42, Madison Street in Malden, being chased by a lunatic with a knife. Okay, now you have my full and undivided attention. Most importantly, though, don't jam up the air. Keep your radio transmissions brief. I worked with a guy who, as soon as he keyed up the microphone, you knew you were in for at least a 5-minute speech. And it was just chaos and bedlam after that, because he would tell you, this is Bob. I left patient so-and-so in reception on the 3rd floor, second office from the left, in the 3rd chair by the nurse station with the receptionist. Her name is Karen. She likes puppies. And he would go on and on and on and on and on. And guess what everybody else was doing while Bob was talking? Everybody else was waiting.
If you're in an emergency situation where, like you said, you just like, you don't stand by, like as in, like if we're, on the road, we're just driving around and we witness a car accident, it's still okay for us to, if we're not with a patient, to stop, and even if you say stand by, we can go over that, or do we have to wait for?
Oh yeah, if you're getting out of the truck for any reason, dispatch needs to know that. So if they tell you to stand by, all right, A42's out at Main and Madison with an MVC. And then
Okay, so
you'll always have a portable radio with you as well. So it's not like you'd ever just be sort of out there playing in traffic all by your merry. But you know, if they tell you to stand by and there's a legitimate reason why you can't, feel free to keep right on talking. Somebody will get it.
Okay.
Most of the communication with dispatch is just this right here. They're gonna call your ambulance number. So we'll stick with ambulance 42. Ambulance 42. So they called me. Now I respond. It's like you go, I go. All right, this is ambulance 42. They're gonna give me my call information. Head to Main and Madison for a motor vehicle collision. Unknown occupants, unknown number of vehicles. Okay, ambulance 42 acknowledges Main and Madison, unknown amount of occupants, unknown amount of vehicles for the MVC. And I'd say, we're en route. Guess what happens next? I arrive on scene. So the next logical thing I'm going to do is key up my radio, wait that 1 second after I listen to make sure nobody else was talking, and say, ambulance 42's on scene. I do my thing. I get out, I take care of my patient, I load them into the ambulance. When I'm getting ready to leave, we're leaving scene now. Ambulance 42 is transporting. Moving on along through this logical progression of how a call works. When we get to the hospital, ambulance 42 is on arrival, CHA Everett. And then when we're finished, this is the only actual time when a call is really completed, when a call is actually 100% in the books, is when I finally clear that hospital. So after we bring the patient in and we communicate with the nursing staff and we give them our report and we don't abandon our patient, we go back out to the truck, we clear the hospital. Ambulance 42 is clearing in service. And since this is a busy system, back at station's probably not going to happen. They're probably going to give me another call and we're going to wind up wash, rinse, repeat until all the calls are done. And we do finally arrive back at station. This really is just keeping everyone apprised of what it is that you're doing and where you are so that you're never out in the wind and nobody's ever alone. Communicating with medical direction is an art form. This is maybe one of the bigger complaints we receive sometimes, is that people call medical control and have no earthly idea what it is that they want. And what we need to do when we call medical control is have a pretty good amount of this information ready to go. And you see all of this stuff right here on the slide, and it looks big and confusing, and there's a lot of stuff. And that's not really the case, because when in a couple of slides we talk about the method we use to communicate with medical control, it's really very simple. They want to know the situation, the patient background, our assessment, and our recommendation. That's really it. Medical control doesn't need a ton of information from us. They also are very busy and don't need news, weather, and sports. So if we tell them everything we know, front load all that important information with our situation, our background, our assessment, and our recommendation, only one of two things is going to happen. They are either going to give us an order or tell us to transport. That's the way it goes. They're either going to agree with our recommendation and tell us to do something that was within our scope of practice and we can carry out that order, or they're going to tell us, why don't you just transport that patient and we'll see you on arrival at the emergency room. Both of those things are fine by me. When they give you an order, it's very important to repeat it back to them word for word so that they know you understand and you know that they understand, because like I said, with medical control telling us to saw people's legs off and perform emergency C-sections, a lot of the times we're not necessarily even playing the same game, let alone out of the same book. If they tell you to do something that you don't think is right or you found confusing for one reason or another, ask them to repeat it. Because sometimes in repeating their order, remember, they're thinking with doctor brain. They're not thinking with EMT brain. So they may have said something that was what they were thinking they would want to do for this patient, and they tell you to do it. So if there's any confusion, you can't just say, well, the doctor told me to. No, you have to, if something needs to be shored up and you need to get things right, this is the time to do it. And when all else fails, if you still are uncomfortable with the things that they are asking you to do or telling you to do, don't be afraid to question them. Just want to make sure that you heard this is Cataldo BLS 42, and you want us to strap that third patient to the roof on our way to the emergency room. And then they go, oh yeah, probably we don't strap people to the roof anymore. We'll send another ambulance. It's busy, it's chaotic, it's hectic, and we're all sort of the check and balance for the other side of this medical professional team. So here it is. Here is what their fancy little acronym for communicating with medical control. Situation, background, assessment, recommendation. So the situation is what's going on right now. Background is just general patient health information. The assessment is what you found. So situation and assessment are sometimes two completely different things. Our assessment's going to be subjective things and objective findings. So vital signs, blood glucose level, things that my patient has told me throughout my assessment. And then my recommendation is, what do you want? What do you want the doctor to tell you? One of the times that we always have to call medical control is for a patient who is over the age of 65 and is having a significant severe allergic reaction called anaphylaxis. We can provide epinephrine. We have epinephrine in our vehicle. We have EpiPens, no problem. But if they're over the age of 65, we have to call medical control. Epinephrine is a very potent, very powerful vasoactive drug. And when patients get over the age of 65, we're actually worried about causing them more harm than good. So I would say, we're here for an doc. This is Cataldo Ambulance 42 BLS. We are on scene with a 65-year-old male, allergic to bee stings, recently was out mowing the lawn and hit a nest. He's been stung multiple times. My assessment reveals, and then I would paint them the picture of a patient who is in anaphylactic shock. And my recommendation, I would like to administer epinephrine 0.3 milligrams IM with an EpiPen. What do you think? And the doc would either tell me, well, go ahead and transport this patient and hold off on the epi. And I would say, received. Cataldo BLS receives 40, hold off on the epinephrine, transport to the closest appropriate facility. And we're finished. Or the doc would say, no, it sounds pretty significant and severe. I would go ahead and give the epinephrine and monitor the patient, transport to the closest appropriate facility. And I would say, okay, Cataldo BLS 42 receives 0.3 milligrams epi IM with an EpiPen, and we will transport and monitor. And then we're still finished. All they're going to do is say yes or no. Pretty much a wrap from there. You either do it or you don't. When we get to the emergency room and we're going to provide that patient handoff, really what they're looking for is the entire rundown of our patient. So when we call them on the phone or on the radio to tell them this is Cataldo BLS Ambulance 42 en route to the Cambridge, the CHA in Everett, they don't really need the entire story. When we call on the radio, they are looking for a brief report to try and figure out, they're triaging the patient. They're sorting this patient to try and figure out how sick is this patient? How many people, emergency room staff, are we going to need the minute they get to this door? So they want age, sex, and chief complaint pretty much period when we call on the radio. When we get to the emergency room and we're going to provide that complete handoff to the emergency department, that's when we tell them absolutely everything. We are going to tell them all that we know about this patient, all that we have done for this patient, any treatments we have provided to this person, what their response was, what their favorite animal is, whatever you know, now's the time. And you are going to just run off at the mouth and tell the receiving facility staff anything and everything that pops into your mind about things that you know about this person. Why do you think we make sure we get every last detail into this direct person-to-person handoff?
So they don't misdiagnose the patient?
Yeah, so that nothing gets missed. And what happens if this patient gets to the emergency room and goes unresponsive?
They would know exactly what happened or like what the situation was.
Yeah, you might be the exact last person that this patient ever talked to while they were still conscious. So it's important to make sure you get all of the everything you need to into this direct patient handoff. Now, it's nerve-wracking, especially the first couple times you do it, and it's not easy. So feel free to scratch things down. I carry a notepad with me just about everywhere I go. I have a pen and something to scribble on. I would leave work with things written all over my hands, pieces of tape on my leg that had information written down on it, you name it. And then all of a sudden, I'm into my career for a long time, and I just stopped having to do that. But nobody's going to look at you funny if you have to write that stuff down, especially in the very beginning, because I'll tell you what, we've all been there. So there's no reason to just be like, all right, I have to remember all of these things. No, you don't. No, you don't. Let's see what else we got cooking in here. So as a new provider, this is one of the things that a lot of people find most challenging, is taking charge. When you get on scene, and you are on scene because somebody called 911 and needs to be transported to the emergency room, you are it. You are the person running the show. You and your partner are on the spot from that moment in time on. You're the ones that make all the medical decisions. You're the ones that provide all the care and all the treatment. You have to just sort of resign yourself to the fact that even if you don't have an alpha type personality, every once in a while, that dog wants to come out and play, because it has to. You have to be able to show up on scene for a sick patient or an injured patient and just be the person doing the things and not have to worry about, any of the rest of it. Be confident. And the biggest thing you can do, especially to win tons of points with most of the local fire departments, is if they've beaten us there, which most of the time they do, listen to the words that are coming out of their face. They have already done the same assessment. In order to get on a piece of fire apparatus in the state of Massachusetts, you have to be certified at the first responder level at least. Guess what kind of assessment first responders do?
EMT.
It's the same style you guys do. I teach that class. They do the exact same thing. They're limited with some of the treatments that they're allowed to do. So they're going to tell you things that are very important. So listen to them, ask them questions. And then you're going to go and ask the patient a lot of the same questions, because now we're trying to identify a trend in this patient's condition. I want to know, has anything changed since my partners on the fire department asked this patient a lot of questions? Now I'm going to ask them some more, and I'm going to do some more things, and hopefully we can provide some treatment to, at the end of the day, get this patient feeling better. But you have to sort of allow your confidence out. I don't know how else to put that, but don't worry, we'll work on it. You guys will all feel real good about your skills by the time we get out of here. I know that's easy for me to say, but we got plenty of time to work on that. Is operating on the 24-hour or military time clock confounding to anyone out there? So everybody knows how to tell time, like when I say you have to be here for 1300, everybody is cool with that?
I'll be honest, I'm horrible with military time.
All right. Here it is. From midnight to noon, you count 0 through 12. As soon as you get to 1 o'clock in the PM, you add 12 hours to whatever that number is. So 1 o'clock is 13, 2 o'clock is 14, 3 o'clock is 15, and so on, right up until you get to midnight again. And midnight starts over at 0. So 0 is midnight, 01 is 1 a.m., 13 is 1 o'clock in the PM. When you get to the afternoon, you just add 12. Did that make
Thank
sense?
you for that. Yeah, it did. Thank you.
Okay. Let's see what else we got for little tidbits in here. So has anybody ever heard, it's not what you said, it's how you said it? Nobody,
Yes.
nobody has that kind
Yeah.
of, that kind of face?
Yes.
Yes.
Okay.
Yeah.
Every once in a while I hear that. And generally it's not necessarily what you said, it's how you said it. Let's take a look at this guy right here. He may be the nicest human that ever walked upright. What is his body saying about him right now?
He's annoyed.
He's annoyed. Why did you call me with this nonsense? Is exactly the reading I get off of this guy. So understand the message you're conveying to people. People call us when they're in trouble. They don't call us when they're having a good day. So if people call us when they're in trouble and you show up and you look like this, are we making their bad day better?
No.
Make it worse.
No, we're at least making it more stressful. If I were in this call, I would be sitting down on the couch next to this lady, at least pretending to hang on every single word that she said, because this is my one focus. This is my one patient to take care of. So I don't have to be concerned with any of the other stuff that's going along. Make eye contact with your patient. Don't stand there with your arms folded, looming over them. If I didn't sit down on the couch next to her, I would at least be kneeling on the floor so I wasn't, this big 6 foot something giant standing over top of her. It's not always what you're saying to someone, because he could be having a perfectly pleasant conversation with Granny here on the couch. But that message never gets delivered because he looks like he's annoyed. He looks like she's bothering him. So when we talk about patient interaction and patient assessment and those kinds of things, it really is, people are never going to remember what you did. They're never going to remember what you did because our patients don't read our textbook. They don't study our protocols. They have no idea how it is that we're supposed to treat them and what we're supposed to treat them with. Want to know what they will remember? They'll remember how you made them feel while all that was going on. And what do you think this lady remembers about this guy?
He was lorded.
That he was a jerk, right? Even if he was awesome, he could have provided the best patient care in the world. But what do you think her take home from all this was?
That he wasn't listening to her.
Yeah, boy, that guy was a real jerk. I hope he doesn't come the next time I have to call 911. All right, that was lecture for today. What'd you guys think?
It's good.
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 It was good. I didn't think it was bad at all.
All right. So, too fast, too slow, just right? Everybody was able to keep up? Tell me.
I think it was just right.
Good
Yeah, it was
speed.
good.
I feel like definitely taking notes was a little bit difficult at times.